All right, so I've got some nice introductions here. I'm going to read the bios for our speakers today. And as you might have picked up on, Dr. Lyon is going to be chiming in before too long. So he's not on the call right now, but will be soon. And I'm going to start off with Wendy. Wendy Bennett is a senior advisor to NCD Synergies. Wendy has worked in philanthropy and development for 30 years for both US-based and international organizations. Since 2003, she's been engaged primarily in consulting and international grant-making strategies in global health, with a particular interest in strengthening health systems and prevention and care for non-communicable diseases in developing countries. Recent clients have included the Medtronic Foundation and United Health Group. Previously, she served as a consultant to corporate and family foundations across a range of issues and was a program officer at the Archibald Bush Foundation. Wendy lived in Europe for 11 years and has enjoyed extensive travel internationally. She has a BA from Harvard College and a master's in music from the University of Minnesota. Wendy has served on numerous nonprofit boards. She is a founder of the Minnesota Friends of the Children's Heart Fund of Ethiopia, and she serves as a global ambassador for the Nature Conservancy. Very impressive. And Aubrey Davis. Aubrey is the Regional Director of Development, the Central Region for Partners in Health. Aubrey has worked at Partners in Health since 2011, beginning in Rwanda from 2011 to 2013, where she served as the Rwanda External Relations Coordinator. In 2013, she relocated to Boston to join the Major Gifts team, returning to Chicago in 2016. In 2016, she spearheaded the launch of the PIH Women's Alliance. The initiative is designed for women philanthropists who want to work collectively to support and advance maternal and child health in the places PIH works and around the world. Recently, Aubrey took the role of Regional Director of Development at the Central Region of the U.S., leading a team of 5 raising funds from individuals and family foundations across 29 states. She's interested in making philanthropy more diverse and inclusive in order to better serve historically marginalized communities. Aubrey received her bachelor's degree in communication with a minor in East Asian Studies from Wittenberg University in Springfield, Ohio, and subsequently spent a year living and working in Japan with the Japan Exchange and Teaching Program. Following her time in Japan, she earned a master's degree in international communication with a focus on international development from American University's School of International Service. Prior to her work at PIH, Aubrey worked at the World Bank. Man, you guys are just cool stuff. And then I'm going to finally, Dr. Lyon's bio, and then I'm going to turn the floor over to you guys, Aubrey and Wendy. Dr. Evan Lyon is Senior Technical Advisor, Partners in Health, the U.S. Public Health Accompaniment Unit. Dr. Evan Lyon has collaborated with Partners in Health for more than 20 years, first connecting with PIH after living in Haiti in 1996 to 97. He worked between Boston and Haiti for the next 13 years through graduation from Harvard Medical School in 2003 and completing internal medicine residency in 2007. Dr. Lyon moved to Chicago in late 2010 after working with PIH in Haiti through the first year of the earthquake response. From 2011 to 2016, Dr. Lyon was on the faculty of the University of Chicago as a hospitalist and house doctor, serving the greater South Side through home visits for 2.5 years. He also served as a Chief Integrated Health Officer for Heartland Alliance Health, Chicago's healthcare for the homeless organization. Through the first 9 months of COVID, Evan helped found and lead the Chicago Homelessness and Health Response Group for Equity, with a focus on congregate living programs, homeless shelters, residential substance use treatment programs, halfway houses, and in support of people returning home after incarceration. Dr. Lyon rejoined Partners in Health as Senior Technical Advisor on the U.S. Public Health Accompaniment Unit in November 2020. Dr. Lyon's academic interests encompass global health, human rights scholarship and advocacy, social medicine, mental health and substance abuse treatment, prisoner health, and medical education. While not on the full-time faculty at the University of Chicago, Dr. Lyon continues to teach at the college and the Posen Family Center for Human Rights. What a talented group of presenters we have today. Holy cow. With that, I'm going to turn the floor over to Wendy and Aubrey. Welcome.
Thank you. Thank you so much. So I am going to, while I'm working on sharing my, Michelle, it's saying I'm not able to share my screen. Is that something you would be able to?
I just gave you permission.
Okay, let's see. So I'm gonna kick us off. Let's see. And then I'm going to just give an overview of Partners in Health and the work we do. And then Evan is going to talk from a more personal perspective about the work that he did in Haiti, and then help us understand how the lessons that we've learned in Haiti and beyond over the last 35 years have informed our COVID response here in the United States. And then Wendy, who is a trustee of Partners in Health, is going to talk about her personal work that she does with Partners in Health through the NCD Synergies initiative. And then we would love, hopefully we'll have enough time to have some really great questions and discussion about the presentation today. Can everyone see my screen okay? Okay, great. So Partners in Health, we are a nonprofit social justice organization. We're striving to make healthcare a human right for all people, starting with those who need it most. So we go to the most impoverished, most hard to reach communities. Our mission is to provide a preferential option for the poor in healthcare. That means first helping the poor by establishing long-term relationships with sister organizations based in settings of poverty. Partners in Health strives to achieve two overarching goals. First, bringing the benefits of modern medicine and science to those who need it most, and second, serving as an antidote to despair. At its root, our mission is both medical and moral, and it's based on solidarity rather than charity alone. When our patients are ill and have no access to care, our team of health professionals, scholars, and activists will do whatever it takes to make them well, just as we would do for ourselves or our own members of our own families. So we approach each patient as if they're a member of our own family. A little bit of history here. Partners in Health was founded in 1987 by Dr. Paul Farmer, Dr. Jim Kim, and Ophelia Dahl. That's that picture that you see at the top of the screen. For those who are able to watch Bending the Arc, you'll recognize this photo. And if you haven't been able to watch the documentary, I really highly encourage you to. It will give you a feeling of hope in this very difficult time for us globally. So we began working in Conge, Haiti, and this was and still is, a squatter settlement in one of the most impoverished regions of central Haiti. And it was there that this young group of Americans met a Haitian priest named Father Fritz Lafontaine, and together they formulated a rights-based social justice approach to providing healthcare for the poor with roots in liberation theology and anthropology. These philosophical and academic underpinnings led to an approach to providing healthcare that really defied the widely accepted norms at the time around what was possible and what the world's impoverished populations deserved. And at the time, the issues were equal access to drug-resistant tuberculosis and HIV/AIDS treatments. And Partners in Health, using this philosophy, pioneered new treatment methods for the most remote and most impoverished and hardest hit populations in Haiti, and then eventually Peru and Africa. And these early approaches and initiatives eventually sort of formed the foundation of a new movement for global health equity. And PIH's founders and clinicians have really, actually written the book on global health since the late 80s. And we believe that all lives have equal value, and we believe that access to healthcare is a human right. And still, just for example, every day, 800 women, almost all of them in developing countries, die from pregnancy and childbirth related causes. And 15,000 children die each day before reaching their fifth birthday. Most of these deaths are preventable. They're preventable with treatments that have been available for decades, sometimes even centuries. And so at PIH, this to us is a moral injustice, and that drives us to address this injustice because we know injustice has a cure. And we're working around the world to change these statistics. So here's a brief snapshot, and I know it's a little bit hard to read, I apologize. But today we operate now in programs in 11 countries, including a newly launched United States COVID-19 response. And we reach a population of about 4 million people outside of our emergency response. So our core programs reach about 4 million people with primary care services and about 8 million people with secondary and tertiary care. And we have over 18,000 employees, the vast majority of whom are community health workers and local nationals in the countries where we work. Just a couple of numbers to give you a sense of the scale of where we're working. We're in about 278 health facilities in 11 countries, 219 health centers, 41 hospitals, 14 tuberculosis and multi-drug resistant tuberculosis hospitals, in 86 maternal waiting homes and 23 laboratories. And these are, the majority of them are facilities that either did not exist before Partners in Health arrived, or they were decrepit old buildings that had very little by way of healthcare before we arrived. So as Peggy said at the beginning, PIH is a little bit different. So I wanted to explain a little bit of our theory of change and our philosophy so that you can understand what makes us different and why support to Partners in Health is an investment in the long-term health of entire populations. So at the core of what we do is this concept called accompaniment. Accompaniment means that we stand with you, we walk side by side with you, we take your hand, we eat at your table with you, and we work together with you in mutual respect, building trust and exchanging knowledge in a way that is very different from the sort of north-south sort of top-down development implementation that often happens. And that ethos, that approach, is at the center of everything that we do, whether we're, whether it's a patient in a hospital bed or a government partner in an office in the Capitol. So obviously the very first and most important thing we do within our theory of change is providing care. We provide direct patient and primary and specialty care, and we deliver high quality care, ensuring everyone's right and ability to survive and thrive. And then from there, we do training. So we train and employ local community health workers, nurses, midwives, and doctors, and other health professionals. And we provide medical education, we provide training, we provide mentorship to help the local staff have the skills necessary to provide that high quality care that we would all want to receive. And then from there, we use the care and the training to build a body of evidence that we can use to influence policymakers, local governments, and other partners on the efficacy of our model, and then we try to teach them how to replicate it. So we try to demonstrate with that evidence, here's how you can do what we're doing, whether it's in another district in the country, whether it's across the entire country, like we've done in Rwanda and Lesotho, or whether it's advocating for change policies in places like the World Health Organization or USAID. So when it comes to care, which is really the foundation of what we do, we have a care delivery model that is a very comprehensive approach that we call health systems strengthening. It starts in the community with thousands of community health workers who build trust and social capital in patients' homes. Those community health workers are the critical link to the health clinics and health centers where children are vaccinated, women receive family planning and prenatal care, and myriad diseases and conditions are first addressed. And from the health centers, critical patients are referred to the district hospitals that are equipped with emergency rooms, surgical wards, delivery rooms, psychiatric care, laboratories, x-ray machines, and all the medicines, staff, and supplies needed to save lives. And in some countries where we work, we help run referral hospitals for the highest level of care for things like cancer, emergency obstetric care, and we even have performed a conjoined twin separation at our teaching hospital in Haiti. And all this work at the top is the most important piece. And another reason why PIH is different, as Peggy noted, is that all this work is delivered in partnership and at the invitation of the ministries of health in the countries where we work. This is really important to us. We only work at the invitation of the government, and we work in facilities that are owned and operated by the Ministry of Health, mostly by Ministry of Health employees. And the reason this is important is because when your philosophical foundation is that healthcare is a human right, you quickly realize, as Evan can attest in Haiti, that nonprofits are not supposed to confer rights on entire populations. That's really the job of the government. And so if you want people to have the human right of healthcare, then you need to partner with the public health system to build a strong equity-based public health system. And so everything we do is with the support and at the request of the ministries of health where we work. And across this care delivery platform, we invest in what we call the 5 S's of Partners in Health: staff, stuff, space, systems, and social support. These are the fundamental ingredients of a high quality and equitable health system. The first 3 are pretty obvious: staff, stuff, and space. You know, having doctors in hospitals that are well equipped is pretty obvious. It's the second 2 that are often missing in this work elsewhere and can be the most challenging things to do. So, you know, the places where PIH works, they're very difficult environments. And one big reason they're difficult and nobody wants to go there is because they often lack systems. There's no transportation systems, there's no electrical systems, leadership structures, supply chains, reliable HR and payroll systems, trainings. There's just a complete dearth of that kind of systemic support for the health system. And this is the really unsexy stuff that is the foundation of delivering high quality healthcare. And so PIH builds these systems together with local governments. And finally, social support is a critical element of what we do. Our patients are some of the most impoverished people in the world. You know, sometimes, for example, women in Haiti will not come to deliver their babies in the hospital because they're embarrassed that they don't even have a blanket to wrap the baby in to take it home. And that level of poverty will never, you know, just building a hospital will never solve the health problems in that community without acknowledging the social and economic situation that the patients are in. So we look to alleviate those things. We provide transportation costs. We provide maternal waiting homes where moms can come with their children and wait and get fed 3 meals a day while they're waiting to deliver their babies. We provide them with clean water. We build wells sometimes in communities. We build houses. We do the things that we know prevent people from falling into abject poverty because we know when people are that impoverished, they're much more likely to get sick, and it's a lot harder to stay well once they get better. So that social support, that's kind of our like not so secret sauce that is sort of at the core of a lot of the work we do as well. So I talked a little bit about this already, but a couple of other things I'll just touch on is that we are trusted researchers. As Wendy knows well, we are very closely linked with Harvard Medical School and with the Brigham and Women's Hospital, a teaching hospital in Boston. And so everything we do is infused with a desire to generate new knowledge and research that can inform the world about the efficacy of our model and how to improve healthcare for the poorest. And we are part of the communities we serve. Most of our, like I said, most of our staff are local nationals, and all of our staff live in the communities that we serve. We're not in capital cities. We're out in, you know, remote villages that can sometimes take, like for example, Liberia, where Wendy has visited. If you don't take a prop plane from the capital to where we work, it can take 8 to 12 to even 24 hours during the rainy season to go by road. So we are a trusted part of the communities that we serve. And just real quick, before I turn it over to Evan, I thought I'd share a little bit about the impact that we've had in 2019 using this approach that I just described to you. So our community health workers around the world conducted 800,000 home visits. We conducted 1.6 million outpatient visits at PIH supported facilities, 1 million women's health checkups around the world, 58,000 safe births, including over 10,000 life-saving C-sections, 35,900 people receiving HIV treatment, and 18,000 people receiving care for non-communicable diseases that Wendy's going to tell you more about, like diabetes and heart conditions. So that's the, sort of what it looks like on paper. And so I thought I invited Evan to join me today because Evan can really speak to it from a very personal perspective and talk to you about what he experienced in Haiti. And then, how the things he experienced over 15 years in Haiti have helped him in his new role and helped Partners in Health in our new role responding to COVID-19 here in the United States. So I'm actually going to stop presenting now, and so you can all see Evan's face as he tells you a little bit more about his experience at Partners in Health.
Fabulous, thank you. That little picture, I worked in Haiti for 15 years solid, and I have like 3 pictures. So I'm glad you found
the one I could find.
Yeah, it's crazy. I just don't have any. That was a very PIH place that was inside the prison in Saint Marc in Haiti, where we were providing primary care and access to legal services in a pretty tough little spot. I'm really happy to join you all today, and apologies for being a little bit late. I'm going to talk pretty quickly to let Wendy come on and speak about the non-communicable disease work with Jean, who's an old friend and sort of timeline compatriot of mine. As Aubrey was saying, I think what I'd love to get across is a little bit about Haiti and what we learned there, and sort of how that applies moving forward. And the to me, the 2 biggest punchlines are the way that work happens around health equity and building systems, reinforcing staff, and eventually helping governments fulfill on the promise of human rights has been through community health work in various fashions. The United States needs a lot of that, and we have not yet figured out what the Global South has known for decades. Not Partners in Health didn't invent this. The tradition goes back a very, very long time, but we need a lot of that. And the current crisis may give us a toehold to build a better public health human structure based on knowledge that's created in places like Haiti and Mexico and Rwanda and West Africa. And then the second thing, and I'll come to this a little bit with the vaccine work, I think there's also opportunity for some novel ways of approaching community health work within the United States, and I'll kind of land on that. I'm also excited to talk because Rotary has changed the world in terms of vaccination. This group, I'm sure you celebrated in October 19th, in October 2019, the wild type 3 of the polio virus was eliminated from the world. And just over the summer, while we were all very distracted by the coronavirus pandemic, WHO declared Africa free of wild type polio. And so this group has literally changed the world in terms of vaccine. And we're going to need these kind of community efforts ongoing for this particular problem. And the last reason I'm happy is because I'm close by. I live in Chicago, been here about 10 years. My wife's a South Sider. We came to the city to be with family after the earthquake. I had worked on the earthquake for better part of a year in 2010. And as we were picking up our own pieces after that intense year, came to Chicago and have been here ever since, and now part of the public health accompaniment unit in Chicago. For myself, and mostly to kind of set up for questions, I'd be thrilled to answer questions or think about anything that's on your minds and related to Partners in Health, or really public health in general. I went to Haiti when I was 25 after college, before medical school. Before I knew Partners in Health, that year of just doing service and being a teacher turned into 3. When I came back to the US after a year or so, I started with PIH when there were maybe 10 people in the US office, and Haiti was up and running, and Peru was just beginning at that moment, but worked a few years with PIH in Boston and in Haiti a little bit before my medical training. Because of Haiti and PIH type work, I was able to train at Harvard Medical School and then Brigham and Women's Hospital, where so many of our faculty have grown up. I had the distinct pleasure of spending half my residency in Haiti. So normally, in residency, you're tied to your hospital, like you live there as a resident. But the Brigham and PIH had me able to go to Haiti for 6 months every year for a couple of years and work on the expansion of that project from one place, Conge at the beginning, to 6 hospitals and 20 some clinics and a whole infrastructure for treating HIV and TB in the entire center and River Valley, Artibonite Valley of Haiti over the next 10 years or so. And through that, just became intimately versed in community health approaches, because that is the foundation. In a place like Haiti, there's too little resource for clinical care, for teaching, and the way to build infrastructure is with people, right? To bridge distance, to deliver medicines to a periphery, to have a feedback loop so that if someone's in trouble, they have a chance to come in early enough in the process. Even with the massive expansion of PIH over the last, 10 years, 15 years or so, the half of the staff are community health workers. So Aubrey could probably update me, but it's roughly about 5,000 employees in Haiti, and half of those are community health workers, and a very small number are transnational, collaborators, folks like me, and that's still the foundation and will remain the foundation there. Let me jump quick and back into the slides and talk about the public health unit quick, so that you've had an update, and then land on a couple ideas, and we'll come back to Wendy. A couple of things have collided in the last year, and most important is this global pandemic. And while our other country sites have been deeply affected by the pandemic, here in the United States, we've had a particularly hard time of it for all the reasons you well know. Early in the pandemic, the opportunity to help build contact tracing for the state of Massachusetts came to Partners in Health, and that started quite quick. Maybe the next slide. Since then, the team has grown pretty substantially. It's currently 60 people. 11 of us are kind of returning PIH alumni. A large other number are folks who would otherwise be working globally, but because of safety and travel restrictions are not. And so my team here in Chicago are mostly folks who have experience in West Africa during Ebola. And so the same questions of logistics and supply chain, contact tracing, vaccination are familiar to the PIH team because of the global work. I'll talk a little more about partnerships, but we're in 10 places very substantially, a number of other collaborations. There's a learning collaborative that's been ongoing and growing and iterative. I understand that some folks from your community have been a part of that learning collaborative. Is anyone on the line who has participated from Minnesota Public Health or otherwise? Maybe not. It's open and it's ongoing, and it's helping us all just stay focused. Maybe the next slide. So core to the PIH approach here has been this middle piece, and now we're moving over into vaccination. But to get ahead of the pandemic and support people if they do become sick. Contact tracing needs to happen, and really still not happened in a way that it needs to. And so one of our concerns is that these efforts may be downshifted with the new vaccine and with, let's say, an imperfect record of doing contact tracing. But the sort of epidemiology logic of knowing who's been sick, learning who their contacts are, and then eventually vaccinating in a ring like you'd respond to a polio outbreak is what we need. But the infrastructure and the speed and then lack of trust in the public health system has really hampered those efforts. Massachusetts is really well ahead of things, given their early investment in this. Partners in Health is helping support contact tracing through the state of Illinois with the Illinois Department of Public Health, increasingly with the Cook County Department of Public Health. But this core aspect of contact tracing is, epidemic response 101, and still room to improve. I think another really key thing, and back to the principles and approach that Aubrey was speaking to, it's not enough to just contact folks, but if someone's sick and doesn't have the resources to stay isolated and keep eating and keep their heat on, if someone does not have the ability to move other family to safety, if they have no ability to navigate the healthcare system should they get in trouble, that resource coordination is actually perhaps most crucial in the process. Just knowing where someone's sick and where someone is vulnerable is deeply inadequate if the actual issue is that they're poor and they live in a crowded setting and food is insecure, or they have, dynamics around mental illness or drug use or incarceration, just the surrounding social vulnerability that causes inequity and sickness has to be addressed as part of contact tracing. So it needs to be more than a data and a contact mode, but really providing resources and coordinating them up through communities. And thankfully, that work has kind of gone on and has been a huge piece of the advocacy within what Partners in Health is doing to not only track and precisely understand the epidemic, but to move resources to where people know them or need them. I'll talk about vaccine stuff at the end. Next slide. Here's the highlights of where we are. Just quickly, a couple of key things. Immokalee, Florida, is where many of our tomatoes and other vegetables come from. There's a large and very, very impoverished migrant workforce that's there, and living in crowded conditions in trailers and with too little health care. And so jumping in to support the Immokalee Workers Union has been a great thing for Partners in Health. Would highlight that one of my oldest mentors and friends, a guy named Lyon, who ran HIV expansion in Haiti through the 2000s, late 90s and 2000s, has moved to Immokalee. And he is our lead community health worker in Florida. In addition to getting us through Haiti, he also helped set up HIV programming in Rwanda and in West Africa. Frené is a very seriously unsung genius and hero in the global health space. And he's caring for people in Immokalee. And he would also want me to say that he is shocked at the poverty and the vulnerability of these communities. And he knows what he's speaking of. The places he's worked in the world are chosen preferentially for the poor that live there and need service. And Frené's been really shocked at what we tolerate in the United States. There's been a huge commitment from Partners in Health in Navajo, going back almost 15 years at this point, or 10, 12 years. That has expanded through COVID response. Similar dynamics in Pima County, Arizona, a very large county, more than 1 million people. Tucson as a city is quite dominant, but it's rural, it's in a migrant place. The border dynamics are real substantial. And then I want to land on Illinois, where I, have been living, will be living, and now get to work on efforts here. We've been part of contact tracing through the state for a very long time. And over the last couple of months, 2 months, we've landed inside the city to work on vaccine equity issues. And I'll describe that briefly. Our expectation, of course, is that the same inequities, race, place, poverty, other vulnerabilities, incarceration, mental illness, drug use, et cetera, will create inequities in vaccine access. And much of this is structural, right? As the drivers of inequity are, including inequity of access to expanded vaccine availability. But there's also a really crucial dynamic of lack of trustworthiness in the healthcare systems and people's fears. Vaccine is, should they take it? Is it safe? What's really going on? And I didn't say lack of trust because I think it's important to distinguish that our public health systems, from the perspective of someone who is vulnerable, have not been trustworthy, right? They're expensive, they're fragmented, they're hard to navigate. And so part of our job is to create enough good communication that people may develop some trust in the work, and also have a chance to speak to their concerns at a local and hyper-local level with the open-ended approach of letting people make their best decision about the vaccine. So not replicating the dogma of you need to take your medicine, you need to take your medicine. That's going to happen. It's an important message, but there's layers and layers of concern that we need to surface and do in an ongoing way to build some trust. And so that's what we're doing in Chicago, starting at the end of the year and ramping up now. The second key piece of vaccine response, we think as Partners in Health, is expansion of accompaniment, expansion of navigation and other supports in the community. And like in the Twin Cities, and I know less about rural community health approaches in Minnesota, but I know there are many actually. It's a very important public health state for innovation. We have some of those structures in Chicago, and we're working to expand their scope to be able to talk about vaccine and then ultimately help people navigate into the vaccine if they care for it. And this will, I think, be kind of my last point, but this to me is the crux issue from an innovation perspective for domestic community health work. In Haiti, Rwanda, most of these places, the technology of community health work is often to deliver medicines and support outward from to places that are not reached. Analogous to rural United States, there's too few resources and people are very spread. And so community health work is often a directed intervention to deliver inside of communities and provide a feedback loop. In a place like Chicago, the problem's really inverted. There are healthcare resources. And if you're poor and can stay on Medicaid, it's possible to get really excellent care, even if you live in the South Side or Garfield Park on the West Side, these very poor neighborhoods. The trouble is that the system is very fragmented. It doesn't communicate among itself. One place is good for something, another place is good for something. You'd never go there for that. And if you ask a sick person to try and navigate that, it's doomed to fail. That's actually, what's happening. And so the approach we're taking with vaccine, and hopefully can build on, is to really center community health work even more completely in community so that it's able to help people navigate up into care in a way that's agnostic about where that care happens, right? So in Haiti, there are not other hospitals and clinics. Partners in Health has built some, and the community health work is often implementing outward to expand reach and safety. Partners in Health in the United States should probably never be a clinic. We have those. The trouble is people don't connect to them. So I think this approach that's community driven and agnostic about where people get care can bridge that last mile gap and provide some possibility for equity and good outcomes around health. And so we're hopeful that the the warp speed of the vaccine response and COVID response is going to get us to a place where we have some of these pilots and programs up and running within the United States to do exactly what Partners in Health has done in other parts of the world, to strengthen systems, provide pathways for equity, get people to better outcomes, and ultimately, advocate for those systems to improve and to actually function better. That's plenty. I went a little longer than I hoped to. I think we'll just, skip ahead. And of course, I'm thrilled to have questions and conversation.
That's great. Do you want me to jump in,
Yeah.
Aubrey? That's
Please do, Wendy. I was having trouble getting off mute.
No worries. And Evan, that was fantastic, and love to do that introduction. There's so much to say. I need a quick reminder. Are you trying to close at 1/4 or do we have until 1/2? I want to make sure we stay on time.
We try to close at 1/4. Yep.
Okay. So I'm just, there's.
So sorry, Wendy. I'm so sorry.
No. I'm really glad you talked. I learned a ton, and I know everyone else did too. I'm just going to close with about 2 minutes of on the NCD program, the non-communicable disease program, and also why I'm involved with Partners in Health. I've been watching the chat as we've all been listening here, and I know that there are a couple who have seen the film, who know about Dr. Paul Farmer, the founder of the organization, and what a rock star he is in this world. And just encouraging everyone who's here and listening that you don't, although we have wonderful PhDs and MDs that are working on this, this is also a really appealing organization to be involved with and to support. If you're just someone who cares about humanity and wants to see that you're going to make a difference. So what really draws me to this work is that we work across 11 countries. We're really changing the fundamental health system, but Partners in Health I think of as the lead thinker on how we need to fix the problems. And then they share it out across 11 countries, and now including deeper work within the US. We all know from our last year of experience that our public health system is broken in many ways. And Partners in Health came in with this amazing advantage, having worked in 11 other countries and knowing what works and what doesn't in very stressed situations, particularly around infectious diseases, because they've been working on it for 30 years. So Partners in Health draws in the top thinkers globally in public health. It applies solutions to the problems of how to reach the poorest. And then it keeps measuring whether what it's doing really is working as effectively as it possibly can. And it's got great researchers there. It's folks at Harvard and all sorts of partnering organizations around the world. And then they take that learning and they push it out around the world, starting with their folks at Brigham Women's Hospital, but frankly with hospitals that are partners of theirs around the world. So if you decided you could only support one organization that was thinking about public health, I would turn to Partners in Health. They also are amazing humanitarians with huge hearts and a sense of caring that is truly deep. We won't have time today to show some of the videos, but maybe Aubrey, in your follow-up email that you can send out, you could send a couple of links, because in the non-communicable disease program, we've actually spent some deep time in the last couple of years talking to people who are in these very remote, very impoverished settings across multiple countries, many of them children, and talk to them about what it's like and what are the solutions. And each of the patients you're going to see in those videos, you may not know it, but they got help and they got better. So this is a message of hope, and one where I hope many of you will decide, maybe this is an organization that I should be involved in. Maybe I could be doing presentations about it. I could support it. I can tell my neighbors, I can tell my church, etc. In one sentence, the non-communicable disease work says, We are very focused on infectious diseases, as we should, because we see how fast they travel around the world and they can be devastating. But we don't need to wait on all the other health crises that are happening. So we can prevent rheumatic heart disease, which affects 2 to 3% of children in Africa, by getting them medication for strep throat. And we all know how straightforward it is to do that. We just need to focus on it. So we're focusing on type 1 diabetes. Peggy knows there's work on epilepsy. We work on lung diseases. We're really opening the tent and saying we need to be comprehensive. And we're solving the problems of how to do these complex diseases in very impoverished settings. So I'm just bringing that message of hope and excitement. And I'd be happy to talk to anyone who wants to learn more about the organization. And I'm sure Aubrey can make connections for us as well. And I want to thank Michelle for getting us really well organized and being willing to host this, and to Peggy for sort of lighting the match and saying, putting together the spark and saying this is a good connection to make. Peggy has been a wonderful volunteer and supporter of Partners in Health, and this is just another example of that. So thank you.
Wonderful presentation. Oh my gosh. Yeah, I'm sorry that we don't have more time. This is fascinating, and the work that you do in so many different places, we could, I'm quite certain, spend hours and hours. So maybe as a group, we can collectively ensure that we're watching the movie and then see if we want to invite you guys back as we have even more sophisticated questions, perhaps at that point. We are at 1:16, so I want to honor the time that we have here together. I'm very grateful for having our guests from Partners in Health. At this time, what we're going to do is close by reciting the 4-way test of the things that we think, say, and do. So if you'd repeat along with me, please. First, is it the truth? Second, is it fair to all concerned? Third, will it build goodwill and better friendships? And fourth, will it be beneficial to all concerned? And with that, we are adjourned. If anybody wants to stay on for a minute and chat, I'm happy to keep it open, but thank you everybody for joining us today, and look forward to seeing you next week.
Thank you, everyone.
Thank you.
Happy New Year.
If anyone wants to chat.
Yeah, talking about a Minnesota connection, are you familiar at all with Heartline Ministry in Port-au-Prince?
Yes, but not deeply. I know their reputation. It's a good one.
Oh, good.
Yeah. What is your connection there?
Well, Troy lives there, was a student of mine, and as a French teacher in White Bear Lake, and he went on to start a Heartline Ministries in Haiti.
Fabulous. Yeah. And have you been?
Beg your pardon?
Have you been there? Have you visited?
No, I've not been to Haiti. We did have some Rotary clean water projects there, but I never got signed on to one of those.
Yeah. It's a hard time to go anywhere, but it'll change. It'll change.
Yeah, I'd love to go to Haiti.
Wendy, do I see you there in the picture?
Yes.
Yeah. I'm sorry. I thought I was a little quicker, but
No, please don't apologize. It was super. I'm happy.
yeah. How, if you don't mind my asking, you've been involved with the NCD work and with Jean for some time, yeah?
Over 10 years, starting when I did some work as a consultant to Medtronic Foundation, and Medtronic supported a grant, some of the work that Jean was doing originally. It's a wonderful example. It's very exciting. I don't know if, Evan, you've had any updates, but Partners in Health, Jean's work, he's a cardiologist who went over 10 years ago to Rwanda and sort of hung out his shingle and said, I wonder what kind of heart disease there is in a very remote, impoverished area. And most people said there won't be any, because we all think of heart disease as something that happens to elderly people or people who are, not able to get the exercise that they need, et cetera. But it turns out that heart disease is quite prevalent among, particularly among children in these very remote settings. It has different reasons for being, as I mentioned, rheumatic heart disease from untreated strep throat. It causes an inflammation of the heart in some percentage of children, and will really lead to heart failure and death at an early age. And we also know that structural heart problems are the #1 birth defect worldwide. And so there are millions of children across Africa who are born every year who need some surgery for their hearts, and we want to get started on that. So we do this work, and it's led into a very important advocacy movement globally. There are now 15 countries that have signed on and done collaborative work to understand the burden of heart disease and diabetes and epilepsy and sickle cell and a whole cluster of diseases. What's the burden of disease in their country? What are the solutions that are out there for people who live in these settings? What would it cost to put those solutions in place? Do we have the facilities to do it, and are developing national plans for how to approach these? And this has all been supported through a Lancet Commission, a very important global publication, the Lancet, followed by top medical people around the world. And this has all been written up with careful research and launched. And now there are 15, but soon to be 20 countries with the poorest populations in the world living in them that are creating these plans, creating advocacy, and we hope to start to get some significant funding from governments in those countries, and also from donor governments like our own in the United States. Open the door for our willingness to go beyond just looking at infectious diseases. And we hope to create partnerships with organizations in the US, like the Juvenile Diabetes Research Foundation is interested in working on this. There is a wonderful national sickle cell group here in Minneapolis that we hope to get involved. There are conversations going on with the American Heart Association, and how do we find patients in the US who understand these diseases, and they understand the burden placed on families for people who are living with these. Many of them are children, and would they be willing to open their hearts and support a patient in another one of these countries, and try to get that synergy and that humanitarian link engaged. So we're excited about the work, and maybe Aubrey, in the follow-up links, you could send a little bit about that Lancet Commission and advocacy work.
I think it'd be tremendous. And I've not read it. I've heard through friends that it was happening. I haven't, but there must be some summary, like, summary in that edition that would be really easy for people to get a grasp of the breadth of the thing.
So there's a summary, and there's also either a 10 or 15-minute video that summarizes the work and links to, and in language that we can all understand, and links to patients who are, 3-minute videos where patients are talking about what it's like to live where they are, and then how their lives have been transformed by the work of Partners in Health and many others who are working in these areas. So although it comes across as a very focused and intellectual initiative, which it is, they've also made it so that those of us who are not physicians can follow it and get excited about it and feel connected to it. So Aubrey, I'll get you some of those additional links if you want in the next day or so, and we can do a follow-up for those who are interested.
That would be great. Thanks.
Wendy, it makes me want to bring up too that there's been a program in global surgery for quite a time within the Partners in Health, Harvard University, and program in global mental health with Beppe Raviola, a psychiatrist. And those things they're longer horizon changes, but that's the real foundation, right? To change the trajectory of someone living with a chronic illness and save lives, and also, like you said, the long-term burden, right? The to live with juvenile diabetes in any setting, but certainly in a setting of poor resource, is a tremendous burden, not only on that person but their family and often the whole community. It's very exciting. Very, very
yes.
exciting.
It's a tremendous burden, and in most cases, it doesn't have a happy ending. I mean, many of the children just don't survive because the family doesn't have the resources or can't get to healthcare, et cetera. So it's very encouraging to see this work. One of the things that does make Partners in Health, in many ways, almost a solo voice in some of this work, is the idea that we can do more, including surgery. And for all these children who are born with heart defects or for other surgical needs. We're showing time and time again that with some focus, we can get it done, and we can do it to a very high quality in these settings. And so how do you create the connection so that people living in very rural areas can get to that care that they need and get the follow-up? So we've had wonderful leaders. Dr. Vib Kashetri, who's at the Minneapolis Heart Institute Foundation, has been very involved in helping to set up cardiac surgery programs in Ethiopia and Tanzania and other places. We have a number of people locally who are involved in this effort. And Peggy knows about some of our work in Ethiopia. She's Peggy Lekvik here, who's been supporting a particular initiative on that. So, and the great thing again about Partners in Health is they're linking the countries who are doing this work so they can learn from each other and create a body of work that can be seen at a global level.
I did have another question I forgot about. The proximity of cones to the Dominican Republic, does that complicate what goes on at that clinic?
The proximity, it complicates things in a number of ways, but I